love to get mammograms, right? They want to try 5 a year. Or colonoscopies, like I just can't wait to get another one. Or it's like, who likes going to the doctor? Nobody, this is ridiculous, but this has really become a part of the debate that people are using too many healthcare resources. They just want to use them because they don't really have to pay for them. They're paying a premium maybe, if you're employed and you're in a big place, maybe $50, $60 a month, and you just want to get all those healthcare resources. Nothing could be further from the truth. And actually, if someone's doing that, they've got a problem, and they need to see somebody, right? If you're constantly wanting to get access to healthcare services that don't relate to your health. So that's another issue. Women are pitted against men. We know women pay more for health insurance, and that's because of pregnancy. That's not fair. And then even in, I think it's 7 states now, if you're a victim of domestic violence, that's considered a pre-existing condition. And you can be denied, in the private market, you can be denied health insurance, a plan, if they find out that you're a victim, a survivor of domestic violence. It's completely sexist. And that's part of, now they're going to fix that in the new legislation. They're not going to let the insurers do that. And of course, the other central division is citizen against undocumented, right? And the racism is usually directed towards Mexicans in our country, but it's important to note that millions of people from all over the world live in the United States, live in different parts. I work in a clinic that's part of the safety net in Chicago. It's called Fanta's Clinic, and we basically call it sort of the United Nations. We have tons of undocumented from Poland, India, Asia, Africa, the Middle East, you name it, as well as from Mexico. And so what we hear to divide us in terms of this issue, citizen versus undocumented, is they're coming over here to get our free health care. It's so wonderful, our free health care. They just can't wait to get here. And so women have anchor babies, right? They come over, they cross the border just to have their baby. So the baby is a citizen, and then they hope to get our wonderful health care. They're swamping the emergency rooms, particularly along the border states, California, Arizona, New Mexico, and basically blaming them for the crisis, blaming them for when ERs close down, or clinics or what have you. And so this divide and conquer mentality is really, really destructive. And I just want to say a little something about racial and ethnic disparities, because they're so prevalent in our healthcare system. I think it really speaks volumes about the inequality in our country. If you look at the healthcare system, you see the inequality there too. So if you look at any aspect of healthcare, from the rates of uninsured, like who is experiencing really high rates of uninsurance, access to timely care, that's critical. If you look at any type of cancer or diabetes, hypertension, infant mortality rate, life expectancy, for blacks and Latinos, the health outcomes are worse, much worse in many, many cases. And it's really unacceptable. And unfortunately, this legislation we're talking about won't even begin to address that. I just have one statistic. The life expectancy for men in Bangladesh is higher than for black men in Harlem. And that will probably only get worse because of the economic crisis, which, the healthcare crisis and the economic crisis are really two sides of the same coin. So the third principle is, for our movement and how we look at healthcare, is cooperation and not competition. And unfortunately, competition is the central issue at the core of our system, which is problematic. And we constantly hear that we need more competition in the system, right? We just need more, not less. We need more. And you have to ask yourself, well, competition for what? And so the competition works on several levels. One is they're in competition, as I said earlier, for healthy patients, the young invincibles, even though they want to slap them a little bit, but they want them, young, invincible, healthy. They want to compete for them. They don't want anybody who's sick. They don't want the elderly. That's why we have Medicare, because the private insurers didn't want the elderly. And President Obama said about the public option, well, not only was it supposed to keep the insurers honest, those dishonest bastards, right? We have to have a program to keep them honest. But we have to have something to compete with them, because there's just not enough competition in the system to lower prices. Now, that's all wrong, and this is why it's wrong. So we have competition at the core of the system, and what this competition ends up doing is it creates a hostile economic environment within all of the health, all the component parts of healthcare system. If you look at the hospitals are pitted against one another. I don't know the situation here in Madison, but in big cities, hospitals are in competition for the insured, for people who actually have insurance. Doctors are pitted against doctors to get patients. Hospitals are pitted and in competition with insurers and vice versa. The insurers are in competition with the drug companies. The drug companies are in competition with other drug companies to get the hospitals or the doctors to buy their or to use their to prescribe their drugs. The medical equipment companies are in competition with the other medical equipment companies to get their products into the hands of doctors, surgeons, what have you. Home nursing. We do a lot of, to keep people at home. We have visiting nurses. You have all these agencies that have sprung up in competition for these patients, and it's within that competition. I don't have time to talk about. There's a lot of corruption, and there's been lots of scandals over the decades about how this plays out, and competition is at the root of it. Now, hospitals don't actually compete on price. If you go to the hospital, it's really hard to find, or if you try to comparison shop if you need an elective surgery, for example. Although most people don't do this, because it's not like shopping for a refrigerator when you have to go to the hospital, right, or you have to see a doctor. I mean, maybe you could go online and see, well, this doctor's going to do this or whatever. But it's actually very difficult to get information from hospitals about what they charge. I mean, they have a code of secrecy that's really stunning. So doesn't the pharmaceutical industry. They don't compete on price, they can compete on amenities and the latest technology. And that's why you see a lot of advertising, like, come have your baby at our beautiful birthing suite. Come have your MRI in our brand new open MRI so you don't freak out, That's why you see all of that advertising to lure in patients. And this is the competitive aspect. And it's a one-upmanship between lucrative specialties. So an example, in Chicago, we have 4 liver transplant programs, not because we need that many, because we don't. There's just not enough livers or any organs, actually, for transplant in Chicago to support that, but because it's profitable. It's an enormously profitable specialty niche. There's 4 programs. And what we really need more of is primary care. I think most people know that. We need more primary care, but that doesn't make money. Sitting and listening to patients talk about their diet or what have you, they have diabetes, that's not lucrative. So we have all of these high-priced, lucrative specialties competing against one another. And it's interesting, I work in the largest medical district in the country. So within a 3 or 4 block radius, you've got Cook County, which is the safety net where all the uninsured end up. You've got the Veterans Administration right around the corner. You've got the University of Illinois at Chicago, which is a state-run hospital. And then you have Rush Presbyterian St. Luke's, which is a private hospital. And really, it's a microcosm of the competition and the crisis in just those few blocks. So people, everybody in all the other hospitals dump on county. They dump all their uninsured onto us. So we don't get the reimbursements that the other hospitals get. Even the suburbs dump on county, because the further out you go, right, there's no public anything out there. I mean, you're really out of luck the minute you leave the city. They dump all the uninsured on us. The Veterans Administration, of course, have socialized government-controlled, that's right, government-controlled, socialized all those bad words and concepts, and they actually have some of the best health outcomes of any institution. It's the most underreported story in the country. All you hear about is the bad press, and some of that is deserved. But it's not because there's something inherently wrong with the VA being government controlled. It's because they don't put money into the system, right? They're willing to spend, $1 million per soldier for the 30,000 that are going to go to Afghanistan now, but they're not willing to put that into mental health care for all of these men and women who are coming back with post-traumatic stress disorder. So it's a question of money. And there's no competition within the VA. I mean, it's amazing. They have the best electronic medical record system. They have a continuity of care that nobody can match because they're all in the same pool. There's no competition for patients. They don't look at human beings that way. They give them the care that they need. Of course, they negotiate for drugs with the drug companies so they can bring the cost down, so they can offer more things to veterans. So you've got that.